ASCO. Are you hearing me? Yeah. Okay. So presenting at ASCO and World Lung Conference at Singapore. So I split my presentation in two parts. So first of all, I will share with you some abstract from ASCO regarding the first one is the EGFR mutated metastatic non-small cell lung cancer. The second one is in the early stage resectable non-small cell lung cancer. The third one, the ADAURA trial. The fourth one in patients harboring KRAS G12C metastatic disease. And the last one is an up-to-date analysis from the Checkmate 9. So first of all, So first of all, this first trial, Keynote 789, was designed to evaluate the combination of pembrolizumab plus pemetrexed and platino in patients who progressed from first-line TKI. So we are not sure until now. We know that the inhibitor checkpoint does not work very well for this subgroup of patients. However, there are some data, for example, in the Power 100, that subgroup analysis presenting deletion 19 EGFR mutation, they showed a trend of benefit adding the pembrolizumab. So that's why they designed this trial, looking at mostly for these patients. So the Keynote 789 is a phase 3 randomized clinical trial, which included stage 4 non-small cell lung cancer, EGFR deletion 19 or L858R mutation, ECOG001, who progressed after first or second generation EGFR TKI without T790M mutation, or after first or second EGFR TKI with T790 mutation and osimertinib failure, or who failed from the first line osimertinib, regardless of the T790M status. So 492 patients were randomized in two arms, between one arm receiving pembrolizumab plus chemotherapy based in platinum, combination with pemetrexed, even carboplatin or cisplatin 4 cycles. And then the patient received maintenance pemetrexed and 31 cycles of pembrolizumab. Optional crossover was allowed, and the other arm only isolate chemotherapy based on platinum. The stratification factors were the PD-L1 status, the treatment history with or without osimertinib, and geographic region, East Asia or not East Asia. So as we can see in the interim analysis 2, which represents the 16 months after the last patient randomized, the progression-free survivor was 5.6 months in the arm of the pembro and 5.5 months in the arm of the chemotherapy. As we can see, the p-value did not meet the statistical significance, and as well as in the overall survivor final analysis, which means 29 months after the last patient randomized. In the overall survivor, the median was 15.9 months in the arm of the pembro and 14.7 months in the arm of the chemotherapy. Once again, the p-value was not statistical significance. Then they split up in two groups according to the PD-L1 status, the PD-L1 over than 1% or less than 1%. As we can see in the hazard ratio, in the PD-L1 over than 1% was 0.77, and in the other arm, PD-L1 less than 1% was 0.91. Numerically, was a trend for to be better in the arms of the PD-L1, but once again, the p-value did not cross the boundary, so we didn't see any benefit even in the PD-L1 positive and PD-L1 negative. So in conclusion, the 789 trial is a negative trial because this trial failed to demonstrate any benefit of adding pembrolizumab to chemotherapy, even in progression-free survivor and overall survivor in patients with TKI-resistant EGFR mutated metastatic non-small cell lung cancer. So the PFS was 5.6 versus 5.5 months, and the overall survival 15.9 versus 14.7 months. So these results are consistent with we already know about the subgroup of patients that they do not have a good response in inhibitors checkpoints compared to the EGFR wild type metastatic non-small cell lung cancer. So the second abstract is the Keynote 671, which is a perioperative approach in early stage resectable non-small cell lung cancer. So as we know, based in the Checkmate 816, given neoadjuvant chemo-IO for this group of patients demonstrate a good around 24% of pathological response, but in that trial they didn't do adjuvant inhibitors checkpoint in that scenario. So given the new trials, even the Keynote 671, the agent trial, and the new TORC, they were designed to demonstrate if the perioperative approach, giving the inhibitors checkpoints before the surgery and after the surgery, was better than given only before the surgery. So the Keynote 671 is a phase 3 double-blind randomized clinical trial, which included resectable stage 2, 3A or 3B according to AJCC 8th edition. No prior therapy was allowed, able to undergo surgery, and provision of tumor sample for PD-L1 evolution. The stratification factors were disease, stage disease 2 or 3, PD-L1 status, less or greater than 50%, histology, and the geographic region. So 786 patients were randomized between two arms. So the first arm, they received pembro plus cisplatin and gemcitabine for squamous histology, or cisplatin and pemetrexed for non-squamous histology for 4 cycles. Then they underwent surgery and received 13 cycles of pembrolizumab as adjuvant scenarios. The other arm was only the chemotherapy prior to surgery, and then the placebo for 13 cycles. The dual primary endpoints were the event-free survivor and overall survivor. And the secondary endpoints were major pathological response and complete pathological response. So as we can see in the characteristics from these patients, around 40% of patients presented squamous histology and 56% of patients presented non-squamous histology. Regarding the disease stage, around 30% were at the stage 2 disease, 54% around 3A, and 15% are in stage 3 disease, 3B disease. And according to the PD-L1, they were very well balanced in terms of the less than 1 around 34, 1 to 49% around 32%, and over than 50 around 32% of patients. So the surgical details, the majority of the patients who underwent to resection was around 80%, and the lobectomy was the most surgical procedure performed, with 78.8% versus 75.1%. The majority of patients, over the 90%, active R0 complete resection. So according to the event-free survivor, the hazard ratio was 0.58, and the p-value was statistically significant, and 62.4% of patients still free from disease in the arm of the pembrolizumab, and 40.6% of patients were free from disease, progression disease, in 2 years in the arm of the chemo. So as we can see, show the reduction of 42% in terms of the event-free survivor with the combination chemo-IO prior to the surgery, and then 1 year of adjuvant of pembro after the surgery. The pathological response was around 18.1% versus 4.0%, very similar that we can see in the other trial, agent trial, that I will discuss in the next in the final of my presentation. And the major pathological response was 30% versus 11% in the placebo arm. So in conclusion, the perioperative approach with pembrolizumab is a new treatment options for patients with resectable stage 2, 3A, or 3B non-small cell lung cancer, with the median of event-free survival not reached in the pembrolizumab arm versus 17 the arms of placebo, hazard ratio 0.58, and the 2 years event-free survival were 62.4% versus 40.6% in the arm of the placebo. So the other trial, which is a adjuvant trial, the ADARA, presented at Plenaria. So in 2020, the ADARA trial was presented in the virtual ASCO and demonstrated a reduction of recurrency disease in around 80% in the overall population from stage 1A, 1B until 3A. So this year, they Dr. Roy presented the up-to-date analysis from the secondary endpoint from ADARA overall survival. So according to the ADARA trial, is a phase 3 randomized clinical trial, which included completely resected stage 1B, 2, and 3A with or without adjuvant chemotherapy, with EGFR mutation, exon 19 deletion, L858R positive. So these patients, they were randomized, stratified by stage, EGFR mutation, and race. One arm received osimertinib 80 milligrams once daily for 3 years, and the other arm the placebo. So the endpoint was the primary endpoint, disease-free survival, presented at ASCO in 2020, and now Dr. Roy presented the analysis of overall survival, which was on one of the secondary endpoints. So based on the characteristics of the patients, the majority of them were female, from Asian, around 64%, and non-smoker. The mutation of EGFR, most common was exon 19 deletion with 55%, and 45% presented L858R mutation. So according to the ADARA trial, the overall survival was the p-value was met, and the hazard rate for overall survival was 0.49, which means a reduction of death in 51%. The p-value was 0.004. So the trial was positive for the analysis, but the maturity of the overall survival in that time was only 21%. So when they split into the groups, the benefit of adjuvant osimertinib was seen in all the subgroups analysis, regardless of adjuvant or with or without chemotherapy, as we can see in this slide, and also according to even stage 1B, 2, and 3A. But we can see a greater benefit in patients presenting stage 3A disease, 0.37, the hazard ratio. And the benefit was seen independent of the EGFR mutation, but slightly better in patients presenting exon 19 deletion. So in conclusion, the ADARA trial met the overall survival analysis with a reduction of 51% in the risk of death, with P statistically significant for overall survival, for overall population from stage 1B until 3A. So it's the first. So in conclusion, the ADARA is the first global phase 3 study to demonstrate statistically significant and clinically meaningful overall survival benefit with target therapy in this subgroup of populations. However, ongoing issues are down the road, because we are not sure if we are actually curing the patients with the osimertinib in adjuvant scenario, or we are only delaying the recurrency. As we can see in the curves, after 3 years of treatment, the curves start coming together, but do not cross each other. So we need a longer follow-up to have a final idea in terms of a clear idea in terms of overall survival, because at the time that the ADARA was presented in this year, the ASCO, the maturity was only 21%. And for adjuvant scenario, we are still having the overall survival as the gold endpoint for analysis. And the other problem in terms of the other critics in terms of the ADARA is the fact that only 43% of the arm of placebo arm received osimertinib. So even the fact that the FDA approved the osimertinib as adjuvant scenario in 98 countries in 2020, only 43% had access to osimertinib. This other abstract is regarding patients harboring KRAS G12C mutate. As we know, the CodeBreak 200 trial demonstrated benefit of sotorasib, which is an inhibitor of KRAS, for patients pre-treated non-small cell lung cancer harboring KRAS G12 mutate. In this abstract presented at ASCO, they focus only in the analysis of intracranial activity of sotorasib versus docetaxel in a post-hoc analysis for these patients. So they look at for patients with treated and controlled or stable brain metastases. They were eligible if they had brain metastases resected or had received whole brain radiation or SBRT ending at least 4 weeks or 2 weeks, respectively, before study day 1. So in the arm of sotorasib, according to CodeBreak 200 trial, 90-60 milligram oral sotorasib was given versus docetaxel. 23% of patients had CNS lesions at baseline in the arm of the sotorasib, and 16.7% had CNS lesions at baseline in the arm of the docetaxel. And regarding the measuring of the lesion around over than 10 millimeter in the longest diameter, 10.5% were the patient presented in the arm of the sotorasib, and 7.4% in the arm of the docetaxel. So the endpoint was the evaluate the intracranial activity with the overall rate response and duration of response using sotorasib for this group of patients. So as we can see, the time to CNS progression in the arm of the sotorasib was 11.6 months, better than the arm of the docetaxel, which was 6.0 months, hazard ratio 0.67, p-value 0.17. In the other curve, in the CNS progression-free survivor was 9.6 months in the arm of the sotorasib versus 4.5 months in the arm of the docetaxel, with the hazard ratio 0.53 and the p-value 0.03. So according to the overall response rate demonstrated in this trial, 33.3% had response in the arm of the sotorasib versus 15.4% in the arm of the docetaxel. So all these findings are concordance between systemic and intracranial disease control, which was 80% in the sotorasib and 54% in the docetaxel arm. So according to this abstract, this post-hoc analysis of patients presenting CNS lesions is the first randomized trial of KRAS G12C inhibitors to demonstrate delayed time to CNS progression and longer CNS progression-free survival with sotorasib versus docetaxel. The last abstract presented that I will present for you guys is the Checkmate 9LA, which is an up-to-date analysis from this trial. So just refresh, the Checkmate 9LA is a trial which includes non-small cell lung cancer, stage 4, which does not harbor any ALK or EGFR mutation, and to receive one arm 2 cycles of chemotherapy combined to nivo and ipilimumab, and the other arm only chemotherapy. So as we know, the inhibitors checkpoints, they are a standard of care for treating patients with metastatic lung cancer who does not present any driver mutation. So the design of this trial was to see if we give in 2 cycles of chemotherapy, we can achieve better response, better progression-free survival, and overall survival for this subgroup. So during ASCO, they presented the 4 years up-to-date analysis of the Checkmate 9LA. And as we can see, the hazard ratio was 0.74. The p-value was statistically significant. And in 4 years of the analysis of the Checkmate 9LA, 21% is still alive in the arm of the nivo ipin plus chemo versus 16% in the arm of the chemotherapy. When they evaluate the subgroup analysis regarding the PD-L1 expression and histology, we can see a greater benefit adding 2 cycles of chemotherapy for patients presenting PD-L1 less than 1%. So compare the two graphs. In the PD-L1 less than 1%, the hazard ratio was 0.66, and for patients presenting PD-L1 over than 1%, 0.74. So it was slightly better given chemo plus immunotherapy for patients presented PD-L1 less than 1%. According to the squamous histology, the hazard ratio was 0.64, and the non-small cell, non-squamous histology 0.80, which was slightly better in the arm of the squamous cell as well. So regarding they also look at for the patients who discontinued the treatment given the toxicities from immunoadverse events. So 61 patients discontinued the treatment, and even when they stopped receiving the immunotherapy, they still having good response with a hazard overall response rate in 51%, overall survivor in 27.5 months, and I think that's it. So the reason for this analysis is to see if the patient stopped the therapy, they still having ongoing benefit from the treatment, and they saw a benefit on this subgroup. So according to the 4-year follow-up from the Checkmate 9 LA, the magnitude of overall survivor benefit with the combination 2 cycles of chemo plus even EP was greater, and patients presenting PD-L1 less than 1% or squamous histology. According to the 4-year overall survival rate was 23% in the arm of the combinations versus 13% in the arm of the chemo, and 20% for the patients presenting squamous cell carcinoma who actually received the combination chemo-IO versus 10%. So, and the other thing is that the discontinuation of EP and Evo plus chemo, given the side effects, did not impact negatively in the results from the trial, because the patients still having benefit with overall survival around 51%. So now I will discuss some abstracts from the World Conference Lung. So first of all, I will discuss in the early stage scenarios. The second one is for small cell lung cancer, extensive disease. Then I will discuss in the TKI resistance scenarios. The other one, I will discuss the up-to-date analysis from the adagrasib CRISTAL-1 trial. The 5-1, I will discuss one of the trial presented at Plenaria, the FLARA-2, and the last one, another up-to-date analysis from the Checkmate 227. So based on the agent trial, the design of this trial was very similar to the Keynote 671, but instead of using pembro, the agent trial used neoadjuvant durvalumab. So in this presentation, they showed the surgical outcomes from the AGM trial. So according to the agent trial, resectable stage 2A until 3B, according to 8th edition, and no documented EGFR or collaboration was reported. So these patients were randomized, 802 patients between 2 arms. The one arm received durvalumab plus chemotherapy based in platinum 4 cycles, and the other arm placebo. So in the arm of the durvalumab, they received durva and chemo, then they underwent to surgery, and then received durvalumab for 12 cycles, very similar to the Keynote 671. And as presented in another conference, this trial showed that the event-free survivor, the hazard ratio was 0.68, and the p-value was significantly statistic, and the pathological complete response was 17.2% in the arm of the combination chemo-IO versus 4% in the arm of the chemotherapy. So showed a significant benefit of pathological complete response in around 13%. So in this trial, the baseline characteristics from the patients were very similar to the 671 Keynote trial. The difference here is because they used 70% of patients, more than 70% of patients used carboplatin as a neoadjuvant platinum agent compared to cisplatin, which used around 27%. The stage, according to the disease stage, around 30% were at stage 2, 47% in stage A, and 24% in the stage 3B. So the patients were randomized in 2 arms. So in the arm of the durvalumab, 80.6% of patients underwent to the surgery, and in the arm of the placebo, 80.7% underwent to the surgery. Very similar that we can see in the other perioperative approaches, as in the Keynote 671 and the New York trial, that around 80% underwent to the surgery. From these patients who underwent to the surgery, 7.7% complete the surgery in the arm of the durvalumab, and 76.7% complete the surgery in the arm of the chemo. The reasons for the surgical delay were most related to logistic reasons in around 90.5% versus 12.3%. But we saw more delay in the arm of the placebo. So in the arm of the durva, the delay was around 17% versus 22% in the arm of the placebo. So according to the surgical approach and the type of the surgery, majority of them underwent to lobectomy, over than 80% of patients, very similar to the other trials, and the pneumectomy was under than 10%, around 90% of patients underwent to pneumectomy. And the complete resection was seen in the majority of patients, around 94.7% had R0 surgery. So I brought this slide. It was presented by Dr. Tina Cascone during the World Conference, which summarized all the surgery outcomes from the most important perioperative phase 3 trials, which used this approach: chemo IO before the surgery, and adjuvant inhibitor checkpoint. So according to the New York, the R0 resection was around 95%, very similar that we just discussed in the agent trial, which was 94%. And the majority of the patients, around 80% of patients, even in the trial Checkmate 816, which was only a new adjuvant chemo IO, around 80% of the patients underwent to the surgery. Very similar that we can see in the other trials. So in conclusion, regardless of the disease stage, the addition of perioperative durvalumab to neoadjuvant chemotherapy did not impact in the feasibility, the type, approach, or timing of surgery in patients with resectable non-small cell lung cancer, and resulted in numerically higher R0 resection rate. As we can see, more than 90% had R0 resection rate. This other trial is regarding small cell lung cancer. Unfortunately, we know because of the very aggressive behavior of small cell lung cancer and the small arsenal of treatment for these patients, it was very interesting paper presented at World Lung Conference regarding the anti-drug conjugate, which is an infinatamab deruxtecan for this subgroup of patients. So the infinatamab deruxtecan is an anti-drug conjugate, which has 3 parts: a full antibody monoclonal, linked by a peptides based, which cleaver the antibody to the topoisomerase inhibitors chemotherapy payload, and then this anti-drug was destined to inhibit the B7H3, which is one of the immune inhibitor checkpoint presented in lung most of solid tumors. And in the small cell lung cancer, this inhibitor checkpoint, the B7H3, is presented in around 60% of patients with small cell lung cancer. So according to this information, this trial, DS7300AJ101, is still ongoing, but at Singapore they presented only the analysis from 22 patients with small cell lung cancer who has this B7H3 overexpressed in the superficie of the tumor. So they evaluate the patients with small cell lung cancer, 22 patients, and they given a dose escalation of the infantamab deruxtecan from 6.4 milligram per kilo until 16.0 milligram per kilo. And the key and primary of this was the response rate for this patient and duration of response. So the activity of the infantamab deruxtecan was 52.4% for this group of patients with small cell lung cancer, and the median of duration of response was 5.9 months, and the median follow-up for this trial was 11.7 months. So I think it's a good option. I know that the number of these patients presenting small cell lung cancer in this trial is very short, but based on the options of treatment that we have nowadays for patients with small cell lung cancer extensive disease, this is a promising drug that we can offer to the patients. The progression-free survival was 5.6 months and the overall survival 12.2 months. So the IDXD is a novel B7-H3 directed anti-conjugate drug, which continues to demonstrate robust and durable efficacy in patients heavily pretreated extensive small cell lung cancer, including 52% overall response rate, 5.9 months, the median of duration of response, and the progression-free survival 5.6 months, and the overall survival was around 12.2 months. As this is an anti-drug combination, we know that the nausea and hematological toxicities we can see because is a chemotherapy combined with the antibody, but in terms of the side effects, the majority of patients were well presented good tolerance. The other anti-drug conjugate anti-drug combination was the patritumab deruxtecan, which was presented in the Tatianny lung trial. So based on this trial, the aim of the Tatianny trial was to evaluate the efficacy and the safety of patritumab deruxtecan in patients with EGFR mutated non-small cell lung cancer after progression with EGFR TKI therapy and platinum-based chemotherapy. We know that around 15 to 40% of patients with non-small cell lung cancer presents a mutation in the EGFR, and the standard of care for that is the TKI inhibitors, but unfortunately, majority of patients evaluate to resistance to the treatment, and we have a bunch of mechanisms of resistance. And the salvage therapies after the EGFR TKI, most of the patients receive platinum-based chemotherapy with a short benefit of the therapy after the progression. So the Tatianny trial evaluate the patritumab deruxtecan for this group heavily treated who progressed from the TKI and also the platinum-based chemotherapy. So the study population included advanced EGFR mutated non-small cell lung cancer who progressed to EGFR TKI and also platinum-based chemotherapy. Inactive or previously treated asymptomatic brain metastases were allowed, and pre-treatment tumor tissue was required. So they randomized in two arms. In the arm that the Tatianny, the patient received fixed dose 5.6 milligram per kilo, and the other cohort up titration according to dose escalation. But during the presentation in Singapore, the Tatianny was focused on, they present only the overall response rate in the group who received the fixed dose of 5.6 milligram per kilo. 125 patients were enrolled in this trial. So the patritumab deruxtecan showed a clinically meaningful efficacy, and the overall response rate was 29.8% in this group, and the duration of response was 6.4 months. And also demonstrated intracranial response with this therapy in around 33.3%. So it's a promising drug for patients who heavily pretreated by TKI and platinum chemotherapy for EGFR mutation advanced non-small cell lung cancer. So in conclusion, the patritumab deruxtecan provided clinically meaningful and durable efficacy. So the overall response rate was around 30% in patients with advanced EGFR mutated that progressed to EGFR TKI and platinum-based chemotherapy. This drug also demonstrates clinically efficacy in brain lesions. The intracranial response was 33.3%, and the duration of response was 76.7%. So the HER3-DXd has emerged as a promising therapy for patients with EGFR mutated who progressed to TKI and platinum-based chemotherapy. So the other trial is an up-to-date analysis from the CRYSTAL-1, which used another inhibitor of G12C, KRAS, adagrasib, for patients who progressed from platinum-based chemotherapy. So in this up-to-date analysis, it's like a pool analysis from 132 patients who underwent to adagrasib in the second-line treatment. And they also allowed patients with brain metastases if the brain metastases were treated and stable. So in this up-to-date analysis, in 2 years, the adagrasib was given in 600 milligram BID orally, as reported in the first presentation of this drug, the CRYSTAL-1. So based on the phase 2 cohort A of the CRYSTAL-1 trial, and at the beginning, 116 patients were evaluated, and the overall response rate was around 43%, and the duration of response was 85%. So, 85 months. So in this up-to-date analysis, they will demonstrate that the benefit of the adagrasib for this group of patients is still ongoing. The overall survival was 14.1 months. And 2 years overall survival rate was 31.3% of patients still alive in receiving adagrasib. And in the patients, and in terms of the progression-free survival, the median was 60.9 months. So according to the up-to-date analysis, 43% of patients still presenting the objective response were observed in 43% of patients, and the duration of response was 12.4 months. They also look at to the patients who harboring co-mutation in the KEAP1 mutation, 5.7 months of overall survival if in the patients receiving adagrasib, and for patients who also has TP53 mutation, the overall survival, the median of overall survival in this group of patients receiving adagrasib was 18.7 months. So even in patients harboring co-mutations, the adagrasib showed a benefit in terms of overall survival. And also they look at for patients with CNS metastases at baseline, which was 26 patients, and the median of overall survival was 14.7 months. And the median for progression-free survival for this CNS metastasis group was 6.9 months. So based on the up-to-date analysis from the CRYSTAL trial, the adagrasib continued to demonstrate durable efficacy with a median overall survival of 14.1 months and 2 years overall survival rate of 31%. Exploratory analysis suggested durable clinical benefit in patients with treated stable CNS metastases at baseline, with a median overall survival of 14.7 months, and clinical benefit in patients who harboring co-mutations. The adagrasib, the most side effects that we also see in the adagrasib is the hepatotoxicity, but the rate for grade 3 hepatotoxicity was very low, less than 10%, but is one of the most side effects from this therapy. And the other exciting, I think, trial was the FLARO-2, presented at Plenaria in Singapore. So in the FLARO-2, they evaluate the combination of osimertinib plus chemotherapy, platinum-based chemotherapy, as first-line treatment in patients with EGFR mutated advanced non-small cell lung cancer. So as we know, the standard of care for patients presenting EGFR mutation is the TKI third generation, the osimertinib. That there is a trial, phase 2 trial, a Japanese trial, OPAL trial, which demonstrate improving overall survival when we offer the chemotherapy to osimertinib for patients presenting EGFR mutation advanced non-small cell lung cancer. However, the OPAL trial was a phase 2 and was not randomized. It was only focused for Japanese population. So the FLARA trial is the first phase 3 randomized clinical trial which was designed to see if we can see benefit in terms of overall survivor and progression-free survivor for patients with EGFR mutation in the first scenario, in the first setting. So they included patients with non-squamous non-small cell lung cancer with deletion to exon 19 and L858R mutation. No prior systemic therapy was allowed, and stable CNS metastases were allowed. So these patients were stratified according to the race, Chinese, Asian, non-Chinese, Asian, non-Asian, or EGFR mutation and performance status. So the patients, they were randomized in 2 arms, receiving osimertinib 80 milligrams daily plus chemotherapy, carbo or cisplatin plus pemetrexed. After 4 cycles of chemotherapy, the patients underwent 2 maintenance pemetrexed and osimertinib, and in the other arm was the osimertinib 80 milligrams daily. The primary endpoint was progression-free survival by investigator assessment, and the secondary endpoints were overall survival, overall response rate, duration response, and quality of life, and progression-free survival too. So based on the baseline characteristics from the patients, the majority of them were from Asian, 25% Chinese Asian, 39% non-Chinese Asian, 35% non-Asian population. The majority of them were not smoking, did not have any history of smoking, as we normally see for patients with EGFR mutation, and 42% of patients had CNS metastasis at baseline. So according to the progression-free survivor, the primary endpoint, the hazard ratio was 0.62 and the p-value was statistically significant. So as we can see, the progression-free survivor in the curve of the combination osimertinib plus platinum pemetrexed was 25.5 months versus 16.7 months. It was positive. So this trial was a positive trial, demonstrating improvement of 80.8 months in the arm of the combination osimertinib plus platinum-based chemotherapy. When they look at for patients presenting CNS metastases, the hazard ratio was better compared to the patients without CNS metastases. As we can see in the left side, the hazard ratio was 0.47 for in patients who received the combination of osimertinib and platinum pemetrexed, and for patients without CNS metastases, the hazard ratio was 0.75. The common side effects seen in this combination was the hematological side effects such as anemia, neutropenia, thrombocytopenia that normally we see in patients who received chemotherapy. And the ILD disease was seen in 3% of patients in the arm of the combination and 4% in the arm of the monotherapy osimertinib. So in conclusion, the FLARA trial demonstrated an improvement of progression-free survival with the combination of osimertinib plus chemotherapy, platinum-based chemotherapy in patients with EGFR mutated advanced non-small cell lung cancer. The hazard ratio was 0.62, and according to the investigator assessment, the median of progression-free survival was 25.5 months versus 16.7 months, improvement of 80.8 months. And according to the blind and independent central review, the progression-free survival was 29.4 months versus 19.9 months, with an improvement of 9.5 months. So we also in this trial, the benefit of the combination was seen in all the predefined subgroup, but mostly in patients presenting brain metastases and harboring L858R mutation. So the last one, I know a lot of trials. So the last one is another up-to-date analysis. I think that this one is the longest follow-up analysis from the inhibitor checkpoint as first-line treatment in patients non-small cell lung cancer. Is the CheckMate 2027. So this trial, just to remind, included stage 4 or recurrent non-small cell lung cancer, which does not present any EGFR mutation or ALK mutation, and no prior systemic therapy. So these patients, they were stratified by squamous or non-squamous. In the first part of the CheckMate 227, the PD-L1 expression over than 1% was evaluated in 1,189 patients, and they were randomized in 3 arms: nivolumab plus ipilimumab, chemotherapy versus nivolumab alone. And the other part of the CheckMate 227, they evaluate the PD-L1 expression less than 1%. So according to the primary endpoint, the overall survivor was the primary endpoint for patients presenting PD-L1 over than 1%, and the exploratory analysis include the overall survivor according to the tumor burden reduction, and also they presented the up-to-date analysis regarding the quality of life. So, so the CheckMate 227 continue to demonstrate durable and longer benefit in patients receiving nivolumab plus ipilimumab compared to chemotherapy alone. The median overall survival was 17.1 months versus 15.7 months in the arm of the nivo and 14.9 months in the arm of the chemotherapy. So as we can see in this 6 years overall survival rate was 22% in the arm of the combination immunotherapy versus 13% in the arm of the chemotherapy. And they also look at for the histology. So in patients, the overall survival was evaluated by histology and as well. And according to the histology, 25% of patients is still alive in the non-squamous histology receiving nivo and ipi versus 16%. When they look at to the squamous histology, 14% of patients still alive with the combination nivo and ipi versus 5% in the chemotherapy arm. They also look at for the PD-L1 less than 1%, which also demonstrate benefit with the combination nivolumab plus ipilimumab compared to the chemotherapy. So in the 6 years overall survival rate for patients presenting PD-L1 less than 1%, 16% of patients still alive in the arm of nivo and ipi versus 5% in the arm of the chemotherapy. According to the histology, 15% of patients in non-squamous histology is still alive in the arm of the immunotherapy combination versus 66% in the arm of the chemotherapy. And for the squamous histology, 18% is still alive in the combination immunotherapy versus 4%. So in conclusion, this is the longest follow-up analysis with the inhibitors checkpoint. So that's why this up-to-date was very important during the World Lung Conference, because it's one of the most long follow-up analysis, which includes the first-line combination nivolumab plus ipilimumab for metastatic non-small cell lung cancer. As we can see, still patients, the combination of nivo and ipi is still demonstrate ongoing benefit and durable efficacy, with 22% of patients is still alive in 6 years versus 13% for patients presenting PD-L1 over than 1%, and 27% versus 4% in the arm PD-L1 less than 1%. So I think that's it. I presented all the abstract, but I have some messages at the end. So I think the perioperative approach is very promising. As we can see, now we have 3 phase 3 trials: the new TORC, the AGENT trial, and the Keynote 671, which demonstrate significant benefit of doing this approach, chemo IO before the surgery, and then 1 year of adjuvant treatment. However, given in the Checkmate 816, we saw a pathological complete response in 24%. In the other perioperative trials, it was around 18, 19%, very similar, but we're not sure who do we for patients who had the complete pathological response, who are the patients that we still have to offer them adjuvant immunotherapy. So we need the biomarkers, the Tatianny analysis to see who are the patients who will present earlier recurrency that we can offer the adjuvant immunotherapy to lower the chance of recurrency and better overall survival. And the other point, I think in this case, the majority of the groups who actually had the greatest benefit with the perioperative chemo IO and new adjuvant chemo, as in Checkmate 816, was the patients presenting this stage 3 disease, so higher risk disease, and PD-L1 over than 1%. So maybe this group are the group that we have to always having a multidisciplinary team board and discuss about this approach for these patients. And regarding the EGFR mutated, we know that based on the FLOWER trial, the hazard rate was superior for patients presenting brain metastasis and for patients presenting the L858R mutation. But we are not sure if we still have to, if you can adopt this approach for everybody. We need to see who are the patients that will have more benefit with the combination osimertinib plus chemotherapy, because we know we can offer more side effects based on the chemotherapy for this patient. So we have this option. Actually, the trial was positive, but we have to balance it. Who are the patients that we will recommend this approach as first line scenarios for EGFR mutated. And the other, I think the promising drugs that we just discussed about in terms of antibody drug conjugate, the infantamab and the patritumab deruxtecan, both in patients heavily treated in the non-small cell lung cancer, that we saw benefit with the patritumab deruxtecan, and for patients with extensive small cell lung cancer that we unfortunately we do not have a lot of options of treatment. So I think this new approach of the new antibody drug conjugate are very promising, showing a robust efficacy in these both scenarios. And to finalize, as we discussed about the Checkmate 9LA and the up-to-date analysis of the 227 trial, the inhibitors checkpoints continue to demonstrate a longer benefit, a durable response for patients with metastatic disease who does not have ALK or EGFR mutation. I think the message for the combination chemo IO, we normally in our practice, we normally offer for patients with PD-L1 less than 1%, because we can see a biggest benefits in this group of patients, and the nivolumab and ipilimumab for patients who are older, that we cannot offer chemotherapy and who presented PD-L1 greater than 1%, we can see more benefit instead of the patients with PD-L1 less than 1%. I think that's it. Thank you.
Great job. So I think you answered the questions in the chat. Does anybody else have any? Are there any other